Welcome, and I hope this finds you in good health. As of today, we'll be talking about nutrition management in traumatic brain injury. You'll be with me, your clinical nutritionist and dietitian, Gilbert Gaston Charles. With the introduction part, traumatic brain injury is the major cause of long-term physical and psychological disability and death. In patients with traumatic brain injury, undernutrition is mainly associated with an increased mortality rate, infections, and worse neurologic outcome. Hypermetabolism and increased catabolism after traumatic brain injury lead to hyperglycemia, protein wasting, and increased energy demand. So we have got so many complications that arise from traumatic brain injury. Let's talk about hypermetabolism and variation in energy expenditure in traumatic brain injury patients. Hormonal changes after traumatic brain injury lead to hypermetabolism by increasing the secretion of corticosteroids, counterregulatory hormones, and cytokines. In this acute phase, energy requirements are increased to about 100 to 200% of the baseline predicted resting energy expenditure. This may persist for several weeks to months, depending on the level of neurotrauma and level of recovery. So we have hypermetabolism state soon after traumatic brain injury. And as how you can see, the energy requirements increase more than the normal resting energy requirements. So the hypercatabolism of brain injury is associated with increased morbidity and weight loss. You'll actually witness this in patients with traumatic brain injury. The American Society for Parenteral and Enteral Nutrition Society of Critical Care Medicine and other clinicians suggest that indirect calorimetry is the gold standard to measure energy requirements in traumatic brain injury whenever possible. However, if indirect calorimetry is not available, a basic weight equation of 25 to 30 kilocalories per kg per day is applied, or a published predictive equation such as Harris-Benedict, Ayrton-Jones, and Penn State predictive equations are commonly used. Well, with my experience, Harris-Benedict is the one that I mostly use to calculate the energy requirements for these traumatic brain injury patients. The Brain Trauma Foundation recommended that traumatic brain injury patients should be fed to achieve basal caloric replacement at least by 5th day and at most by the 7th day post-injury to lower the risk of death. And also, Aspen guidelines also recommend a setup of 33% to 66% of the target energy intake for the first 3 days while assessing patient tolerance levels. So as we can see, within a 1 week moment, we'd need to reach the target calories, but we should not start with the actual calories that this person or this traumatic brain injury patient really needs. According to Aspen guidelines, they suggest that at least from 33 to 66%, that should be the startup caloric input to the patient. So as we should avoid overfeeding, and also we will also see what other complications that we should oversee so as to start with these small ranges of 33 to 66%. Let's talk about delayed gastric emptying and intolerance to enteral nutrition. This is one of the things that actually makes us to start with some smaller volumes and lower calories at least. 45 to 50% of traumatic brain injury patients present with delayed gastric emptying or gastroparesis, and this is one of the major factors for feeding intolerance. Gastrointestinal hypokinesia is usually persists during the first 1 to 2 weeks after traumatic brain injury, according to different studies. There are several reasons for intolerance to enteral nutrition in patients with traumatic brain injury. So let us see what are these reasons that lead to delayed gastric emptying or gastroparesis to these traumatic brain injury patients. Neurotrauma increases intracranial pressure and damaged autonomic nervous system. When you have a damaged autonomic nervous system, it is more evident that we can probably be having gastroparesis issues with these traumatic brain injury patients due to increased intracranial pressure, which damage the autonomic nervous system. But also sedatives such as opioids also delay gastric emptying, which consequently increase gastric residual volume. So even the treatments that these patients are being given sometimes can also lead to gastric emptying delaying. Also, pain from the trauma, fascial fractures, oral injury, and prolonged cervical immobilization lead to delayed gastric emptying. Remember, most of the traumatic brain injury patients have severe conditions and they cannot move, so they are immobile. And this makes them to have a cervical immobilization, which can lead to delayed gastric emptying as well. The American Dietetic Association recommends positioning patients at 45 degrees head of bed elevation position to prevent aspiration pneumonia and minimizing gastroesophageal or laryngoesophageal reflux while meeting requirements in less volume. So you should also consider putting your patient at 45 degrees resting position to avoid aspiration, because these patients will also will have a delayed gastric emptying, and this can be a risk towards gastroesophageal reflux. Then concentrated enteroformulas of greater or equal to 1.5 kilocalories per meals may help meeting requirements in less volume. Remember, we should feed these patients with less volume, but also you should be so conscious about the energy that you're providing to your patient. So with these patients, we'll actually give them a smaller volume feed, but these smaller volume feed should have calorie dense. So the recommended formulas are 1.5 kilocalorie per meal. Also, continuous infusion has shown to be better in tolerance than bolus feeding practically. So when we talk about it in practically, the continuous feeding and the bolus, then the one that is much better is continuous feeding to this patient, or continuous infusion. Apart from the bolus feeding that we provide certain quantity of volume in a short time to the patient, and this can lead to also gastroesophageal reflux to most of the patients practically. So continuous feeding could be better than bolus feeding. What more? Aspen recommends that for patients with risk of swallowing aspiration, prokinetic medications such as metoclopramide and erythromycin may be initiated where feasible. However, metoclopramide should not be used to traumatic brain injury patients with seizures and patients on medication causing extrapyramidal symptoms, as it may increase the frequency of duration of the seizures. This is something that we should all note very much. Also, low fat, less than 30% meals are preferred for gastroparesis because high fat meals may further prolong gastric emptying. This is the normal physiology. As we all know, fats will always increase will delay the gastric emptying process. So as long as these patients are at risk of also having aspiration and some other stuffs, then it is much better that we should reduce the amount of fats in their total calories that they receive from combination of carbohydrates, protein, and the fats. So what is the best route for feeding? Is it enteral or parenteral? Take 5 seconds of thinking about this. Enteral or parenteral? Yes. Both Aspen and Aspen guidelines recommend initially early enteral nutrition within 24 hours to 48 hours. This is more beneficial, especially in high-risk patients. For hemodynamically stable patients, then use enteral nutrition over parenteral nutrition. This is recommended. Gastric access is the standard method for initiation of enteral nutrition, and gradual increase is necessary to avoid overfeeding in the early phase. So we start with the small feeds and we increase them gradually until we reach our target, while looking at the tolerance levels of the patient and if there will be a reflux and so forth. Initial rate of 20 meals per hour is appropriate with an increase of 10 to 20 ml per hour every 6 to 8 hours to reach target amount. So, it is recommended that supplemental parenteral nutrition is initiated after 7 to 10 days if it is not possible to meet greater than 60% of energy and protein requirements through enteral route alone. So, as you assess your patient after 7 or 10 days, then if the patient cannot meet the energy requirements to at least 60% of the energy that the patient needs, then that's when we will introduce parenteral nutrition support. Well, let's see protein support in patients with traumatic brain injury. The importance of protein goes beyond its role as a simple source of calories. It is the most important caloric nutrient for the recovery of brain damage, immune function, and maintenance of body mass. Protein supplementation is very important for patients with insufficient enteral nutrition to create a nitrogen balance as the steady loss of nitrogen continues for about 4 weeks. So we have a steady loss of nitrogen with these traumatic brain injury patients according to the metabolic stress that has risen from the traumatic brain injury. And so what should we do now is that we should make a nitrogen balance by supporting these patients with protein feeds or protein supplementation, and that will be even much better. Protein requirements are estimated to be in a range of 1.2 to 2 grams per kg per day of actual body weight for trauma patients. That should count for 15 to 20% of total calories, for which administration of at least 2 grams per kg per day is required. Immune modulating formulas may be applicable option for achieving a sufficient protein supply in order to minimize negative nitrogen balance after traumatic brain injury. The same thing that we have talked on the previous slide. So what are the standard or immune modulating formulas? After brain injury, excessive release of glutamate and exocytoxic excitotoxic neurotransmitters increase the intracellular calcium and sodium influx and results in energy depletion. So formulas with immune modulating nutrients such as glutamine, omega-3 fatty acids, arginine, and nucleotide have been recommended for traumatic brain injury patients. As we all know, the importance of omega-3 fatty acids, arginine, and glutamine. So to counter this effect of energy depletion in these patients, the formulas that should be used for traumatic brain injury patients should also include these stuffs: glutamine, omega-3 fatty acids, arginine, and nucleotide. In trauma, more glutamine is metabolized than produced. Studies have shown that glutamine enteral-rich formulas reduce infections and length of stay in patients with moderate to severe traumatic brain injury. Omega-3 polyunsaturated fatty acids, which include EPA, that's eicosapentaenoic acid, and DHA, eicosahexaenoic acid, are important for appropriate brain development and function through regeneration and repair of the central nervous system after traumatic brain injury. So we see, why do we need glutamine and why do we need the omega-3 polyunsaturated fatty acids? L-arginine is the precursor for most of the several active compounds such as creatine, ornithine, phosphocreatine, and agmatine. So pre-arginine supplementation is associated with improvements in the immune response and protein synthesis. Branched chain amino acids, that's valine, isoleucine, and leucine, requirement increase in traumatic brain injury patients and are essential for glutamate synthesis in the brain and are essential for neurotransmitter cycling. So we all see, if we are to provide formulas, supportive formulas, feeding formulas to our patients with traumatic brain injury, then it is very important that we should consider formulas having these nutrients. Glycemic control in traumatic brain injury. Blood sugar control has a positive effect on the outcomes of patients with traumatic brain injury, despite hyperglycemia being associated with injury severity and poorer outcomes. So let's talk about this very clearly. Avoiding excessive hyperglycemia that's greater than 10 or to 11 millimoles per liter, and sustaining permissive glycemic control between 8 to 11 millimoles per liter are currently recommended, since studies show that the patients with traumatic brain injury randomly assigned to intensive 4.5 to 6.0 millimoles per liter glucose control experienced more frequent moderate to severe hypoglycemia than the conventional. So the recommended range that we should see that is healthier for these traumatic brain injury patients is 8 to 11. This will help us to avoid hypoglycemia moments with the traumatic brain injury patients. Though, as you can see the first paragraph, despite hyperglycemia being associated with injury severity and poorer outcomes. So the studies have shown that having 8 to 11 millimoles is currently recommended. At last, I would like to say thank you very much. We serve to serve, and thank you very much. You're with me, Gilbert Gaston Charles, your clinical nutritionist and dietitian, but furthermore, I'd like to acknowledge the University of Dodoma, but also acknowledgement to the Tanzania Clinical Nutrition and Dietetics Students Association, TACNUDISA, acknowledgement to the Nutrition TV that brings into connection most of the nutrition and dietetics students all over Africa and some other countries apart that are out of African continent. And furthermore, thank you very much for your time, and you can subscribe for having notifications on other videos, but also you can go through our previous case studies videos and other educative videos on nutrition and dietetics practice. Thank you very much. See you soon.